So we said yesterday that we were keen to think about how we can start to reconceptualise responses to poverty-related distress in a way that avoids either just blaming neoliberalism or, on the other hand, that avoids absolving people from all responsibility for their own lives. And we've been looking at how we can restructure consultations, GP consultations, in a way that better supports patients without placing undue pressure on GPs at the same time. So in this session now, what we want to do is demonstrate how we've used the findings that we talked about yesterday to try and inform the development of guidance materials for GPs who are working in low-income communities. And again, just for those of you that weren't here yesterday, the aims of DeStress are to look at how welfare reforms and austerity are affecting mental health in low-income communities, to look at the role of narratives of responsibility in the medicalisation of poverty-related distress, to look at the main treatment options, antidepressants and talking therapies, look at how they're actually being used, how that use plays out in low-income communities and what that actually means in terms of people's mental health and well-being. And really importantly for this session, to try and understand some of the challenges facing GPs who are working in low-income communities and what kinds of things constitute good practice for supporting patients here, what good practice here might look like. So just to recap on some of the things that we've been talking about during this conference in terms of how deprivation and adversity affects mental well-being. Well, we've talked a lot in sessions yesterday and today about some of the humiliation and shame that people feel when they're living in low-income communities and are constantly reminded by these narratives about their circumstances. And it's particularly apparent for people in the benefits system having to go through all of the benefits processes and the kind of stresses that they cause. We talked about the lack of positive physical, cognitive and emotional stimulation, particularly for people who are in really alienating types of work, 0 hours contracts, that kind of thing. We've talked about the way that adversity can affect mental well-being through impacting on an exacerbating physical illness, and the way it's linked with and exacerbated by what we consume in terms of food, alcohol, drugs, tobacco, and so on. And again, we've talked a bit about problematic relationships and violence. Now, we know very clearly that the use of antidepressants and talking therapies has risen. For those of you that didn't see this map yesterday, what this shows is the sort of hotspots of antidepressant prescribing across the UK. So the red areas are the areas that have got the highest levels of antidepressant prescribing. We know also that rates of prescribing for other medications that are associated with the challenges of poverty have also increased. So things like gabapentinoids, antipsychotics and opioids, the things that are kind of used to manage pain and distress, they've also shot up as well. So we talked yesterday about the kinds of impacts this was having on low-income communities and on GPs. Now we're going to be using these findings to work in conjunction with Health Education England and RCGP to develop some training materials for GPs. So we've put together some draft materials already and we've trialled these to some extent with GPs and health professionals from across the Southwest, as well as with GP trainees as well. What I'm going to do now is hand over to other people in the team. So starting off with Richard, like yesterday, it's a multi-pronged approach. We've got lots of people talking here, so bear with us. And Richard's going to give us an overview of what's currently happening in clinical practice and talk through some of the key messages we're incorporating into the guidance materials that are going to help us to reconceptualise how we can more effectively respond to poverty-related distress.
So we start with what we think GPs tend to know already. Empathy is helpful, social problems lead to mental health problems lead to social problems, mental health diagnoses can change over time, medication and CBT don't always work. It feels like more time is needed as so many people come to see us, and it can be stressful supporting people in distress. I'd like to just focus a little bit on the problems of the NICE approach, which is effectively a detect and treat approach, list of symptoms equals diagnosis, give treatment. And there are problems with the science behind this when you have mental health being a continua, it's a spectrum of wellness and illness. It's not, you're not either entirely a disorder or completely well. There are problems in the sense that the mental health problems that we've seen, they are effectively a mix, however you want to conceive of it, of social issues and what's going on in the brain at the one and the same time. But they're portrayed as a specific medical illness. And then the low precision of interventions with small effects. So when you have therapies and antidepressants that have small effects, it actually changes the clinical reasoning for how you should use that. If you have a cataract, you know that it's there, it's very specific. You have surgery that is almost 100% likely to give you your sight back. It's easy. There is no problem with this decision making. When you have an issue which is a little bit too mixed up and complex, and you can't pin it down, and then you have treatments that are based on a construct that is a model that's not very good, and also the treatments don't seem to work very well, then your clinical reasoning should change. We shouldn't be following the same clinical reasoning as a cataract operation because we need to think we also have problematic predispositions and learnt behaviours as individual practitioners. So we're not always very good about thinking about what our patients are thinking and understanding that we may not be able to accurately, however brilliant we are, predict exactly what another individual is thinking. We don't understand their experience. We have to listen in order to understand that and hope they're telling us what's happening. Eliciting symptoms to clinch a diagnosis is a great game. You get your checklist, and then you have it, and they're there. That's fantastic. You've got your diagnosis. Confusing association with causation. If somebody's got better after they start antidepressants, we don't know, and they don't know, whether that's because the antidepressants worked, because they were going to get better anyway, because of something else going on, or whether there was a placebo effect or something else. Lastly, thinking it's our role to fix everything can certainly be an issue that we'll look at a little bit more. As professionals, we're taught to do that. So we want to try and create a reconstructed model, really engaging at the human level, from diagnosis to understanding, and towards making small differences in multiple ways, rather than thinking we can fix a disorder.
Okay, right. Hello, conference. To those of you that were here yesterday, I'm Debbie from deprived Devonport. Okay? This afternoon, I'm Debbie, part of the community team of the DeStress Project. And I just want to very briefly give you a little bit of one of the journeys I've had in my life where I truly hoped that GPs could have helped me, but it took a lot more than a GP to sort things out. I have to say I've already been given my 5-minute warning, so you're quite safe. Okay? I will begin. Okay. Ollie lay lost on the metal frame bed. His torso, sunken and sallow, resembled the carcass of a well-devoured Sunday lunch chicken. His skin, tissue paper thin and webbed with fine broken veins, covered his bony rib cage. I tried so desperately hard not to notice that sunken vessel that was supposedly my son. But it's so difficult to avoid. I couldn't speak to Ollie without sneaking a peek of his Simpsonized body. My son Ollie, in 2009, was diagnosed with anorexia nervosa. At that time, I was a health and social care lecturer at local colleges. And whilst I, as a mother, felt there was something severely wrong with my son, I couldn't put my finger on it. The guilt that hit me when I found out it was anorexia. I took Ollie to the GP so many times. He came forward with lots of aches and pains. He was given a 6-week course at the local zone centre for brief counselling. That wasn't the issue. Anyone who knows about anorexia knows how secretive and manipulative the condition is. I thought that my son was eating, and what he was doing is laying the table, setting the scene of having something, of having had something to eat, but he hadn't. And he did that for a very long time. He changed his clothing, his peer group changed. He wore the great black heavy clothes, really baggy, eyeliner, makeup, went out all weekend with his friends. I'm thinking he's enjoying his teenage life. But he wasn't. He was dying. So the guilt I felt when I was told he had anorexia devastated me. He was placed in a psychiatric unit. After 2 months, he was discharged under my care because, according to the CPA, there was nothing they could do to help him. I had to leave my job. I became 24/7 carer. My friends and my family deserted me. They couldn't talk about anorexia. They didn't understand it. How on earth could someone not want to eat? So, 24/7 carer, no money, not the money I was used to. That wasn't coming in. I couldn't even get a carer's allowance because the people on the other end of the phone didn't understand that anorexia was a severe condition, a life-threatening condition. My friends and family, I've mentioned previously, they deserted me. And it wasn't physically deserting me. I didn't get my phone calls anymore. I've got 1 minute left. It's really a shame. But I'll tell you something. I kept going to the GP. My mental health suffered terribly. I became so disassociated with the life that was forced onto me that had there been a cliff there, I would have stepped over it. So, very briefly, going to my GP with certain issues I wanted to talk about and certain issues I couldn't talk about. I couldn't bring myself to talk about things. The different labels I had as mother, carer, former health and social care lecturer, from professional. How was the GP viewing me? I was there as a distressed person. So I think it's really important for GPs to know about the person. And your question about maybe something about the social environment, where the people are coming from, it's really important. Let's have a whole person, whole system approach to things. Let's know about the person in front. Forget the labels, just look at the person. I could talk forever, I'm sure you'd understand that, but I don't want to have you crying. All right? So thanks very much.
So by thinking of an individual in these real things, and I think low mood is a real thing, whereas depression is a model for what's going on. So feeling low is a real thing. So having a conversation about the real things that are happening and having a model that might just guide a practitioner to think through the important domains of an individual, and then we'll start to point to what might be important for that individual. So the causal links, one way or the other, are important in thinking about what you might do first. So there's a kind of, I'm not going to dwell too much on this, but there are some interesting things that we might want to prioritize in the medical curricula that are helpful in this, rather than a traditional diagnostic model. So theory of mind, we can only guess at another's thoughts and beliefs. They might be thinking that as a practitioner, you think that they're an inferior person, they're useless, they're worthless. So sometimes you just need to say something that shows that you share a common humanity. Being very clear with them about the science behind emotion, the impact of trauma on how the brain develops, so that gives them a kind of validity. If they've had trauma and loss and neglect and humiliation, and their emotions are up and down as in the man in the video, helping them understand that that's understandable given what you've gone through with the terrible trauma you've had. I think brain plasticity, understanding that the brain's changing, offers hope. So there are some hints at how a different way of understanding that might be kind of quite scientific, that might appeal to doctors as an alternative model, might be helpful. So from being a fixer to working towards, from being a fixer to working together towards making small differences is really important. And we haven't found anything either in any of the evidence, and I was talking with Daisy, who you can hear from in a minute. There doesn't seem to be very much evidence about what you do to help people not be a fixer, and what you do instead. And so what kind of conversations you have. So it's something we need to work on, because the evidence isn't really there. So the second proposition is very much building on what Chris has said, so I'm not going to go into that, but the individuals, communities, family doctors, third sector charities need to work together collaboratively to ensure individuals can generate well-being through psychological, social and medical interventions, working together, often or generally not using a diagnosis or resorting to medication. So that we need to transform the current situation where you've got individuals waiting to see primary care, they end up on medication or waiting for therapy or rejected by mental health services. There's an isolated, unsupported community resource. We need to transform that, and this is linking the consultation work with what we've talked about this morning and yesterday, to a system where often people don't go to the GP even. They can see what's there in the community. The community has a supported, protected and resource where there's a kind of where shared understandings of mental well-being and ill health are more understood, and therapists and GPs are supporting that community response.